पता कैसे चलेगा लाइव है? योर कैमरा इज टू लो, चेक दिस। देखते भी हो सेटिंग यार। कैमरा पोजीशन तो एटलीस्ट चेक करो। लेट्स स्टार्ट। कैमरा पोजीशन तो एटलीस्ट चेक करो। लेट्स स्टार्ट। कैमरा पोजीशन तो एटलीस्ट चेक करो। बाप रे। Yeah, so I think I'm live, and we are ready to start with this very quick kind of fast track discussion of the orthopedic class. All right. Hi, good evening, everyone. So those who are with me on the DBMCI live app and those who are with me on the YouTube. So our first session is going to be an open session for all those who wish to revise the complete content of orthopedics in a very quick span of time. All right. So basically, I must tell everyone that this TND session, which you are able to see on the YouTube channel right now, the first part will be free and it will be like open only. And after the second session, like after completion of the first session, we'll be closing it up. And all the students who are with me on the DBMCI live app, I'll make sure that we revise the complete orthopedics, in these span of time that we have today. So let's start. All right, so these questions, guys, these questions are kept as a random questions. I have purposefully not kept them in a section like metabolic disorders, trauma, tumors, infection, because then what happens is, what I've realized over the period of time is that most of the time when question is from a like particular topic, metabolic disorders, the answer is already fixed in your mind that yes, it is osteoporosis, yes, it is rickets only, it is malacia only. We don't have to do that, and we have to prepare our mind according to the exam pattern. Every question will be random in a random, manner. Every subject will be there. All right. So I think I'm very much audible, clearly visible. Yes, everybody has confirmed it, and now we can start. Okay. So my plan will be whatever topic we read, we'll try to make up some important tables, and by the means of tables, we'll try to revise all the orthopedic that we have already read in our classes, whatever notes you have. Okay. So first of all, these questions are made as per the latest NEET pattern, the INI pattern, whatever is expected. And I do believe if you're like seeing this lecture, then you are mentally, prepared that how the questions are supposed to be, right? And now it's the time to revise the complete orthopedics. All right. So let's talk about this. 18-year-old child, the first question, the very first question we start with, the 18-year-old child sustained an injury at the elbow region. It was managed conservatively by plaster application. Gradually, he developed deformity around the elbow and also now is getting gradual flexion of the medial two fingers. What is the most likely injured site in this patient? What do you suggest? What is the problem? Can anybody say? All the people try to answer as much as you can. If you're wrong today, you will never be wrong in the exams. And if you're right today, then definitely you know the correct answer as well. So both the ways you win. Okay, so try to answer. What do you suggest? Number one, the question number one. The child is having injury at the elbow, managed conservatively, then he developed a deformity around the elbow and now he is getting gradual flexion of the medial two fingers. Okay, tardy ulnar nerve palsy. All right, accepted. So basically our question is pointing at what? The question is pointing at the tardy, the late involvement of the ulnar nerve. And you all know that the tardy ulnar nerve, late involvement of the ulnar nerve is a complication of what injury? Lateral condyle of the fracture, the lateral condyle fracture of the humerus. Absolutely right, lateral condyle. Everybody is right. Very simple, right? Very simple question. Look at the second question. 40-year-old man has sustained injury and severely, comminuted fracture as shown in the X-ray. So X-ray is showing you X-ray showing you what? The comminuted fracture of shaft of humerus, and is now unable to flex the elbow, and there is sensory loss on the upper aspect of the forearm as well. What is the most likely nerve involved? What do you recommend? What do you suggest? Now this 40-year-old man, what do you think is the answer for the question number 2? And this is a replica of the question which has been asked in your NEET exam 2021. Okay, so if you look at the shaft of the humerus, if you look at the shaft of humerus, you know that the most commonest nerve involved in the fracture shaft of humerus is usually radial nerve, right? But when you see the presentation of the patient, what is they are telling you? That he is unable to flex the elbow, and there is what? Loss of sensation on the upper lateral aspect of forearm. That is being done by musculocutaneous nerve. Absolutely right. So my message to all of you here is that all the time when you're looking at a question in your exams, don't ever get super excited that it is a question of radial shaft only. So it is a humeral shaft only. So it has to be radial nerve. No, it's not like that. Focus on the presentation of the patient. They might be telling you about the proximal humerus fracture, and then they tell you that the patient is having difficulty in or weakness in the external rotation of the shoulder. Okay, so don't be just focused on the first line. Read it very, very properly. So what is the presentation? And that is a difference we have in the patients who are being asked in your NEET exam, and what is the presentation nowadays in your next exam. All right, so that is the difference. So what we can do, see one more very, very interesting case, very, very interesting. This is one of the patient who came to our orthopedic group in the WhatsApp group very, very recently, and I'm sharing that case with you. This is a 7-year-old child presented in OPD with the presentation as shown in the picture, and history that he is a case 7 days old trauma. It was managed somewhere conservatively, and what is the most likely injury around elbow that can produce this presentation? What do you suggest? What is the child suffering from? Can you appreciate something? If you look at the picture, what is your opinion? What is the answer for this question? If you observe, what are the clinical aspects that we can see in this child? Number 1 is a tight bandage. Number 1 is a tight bandage. Okay, that is number 1. Second, can you see these blisters? Yeah, so now we have a divided opinion of everybody. Tight and blisters. Can you see the forearm getting a swelling? Can you see the fingers being kept as a claw like that? So kind of claw hand. Where do we see this kind of problems? And these blisters, all the time the blisters are suggestive of what? Blisters are suggestive of what? The raised pressure in the limb. These are suggestive of what? The raised pressure post-trauma in limb. Can you see this tight bandage here? And that bandage has been applied. Yeah, very good, very good. RC, buddy, this has they have tell the correct answer. They have told the correct answer. So it is raised pressure, suggestive of what? The compartment syndrome, as you said. Absolutely right. Okay, so yes. And what is the most commonest fracture around the elbow? You all know the answer. It is supracondylar. Lateral condyle usually doesn't produces the this kind of you can say the raise in pressure or compartment syndrome, because lateral condyle goes into some other complication. What complication? What is the most common complication related to the lateral condyle? What is the most commonest complication related to the lateral condyle? Is that if it is not operated surgically, it goes into what? Non-union. It goes into what? Non-union. And supracondylar being a metaphyseal area, usually it unites. And union doesn't mean that it is always in an anatomical position. It will unite, that is for sure, but not always in the anatomical position, and that is known as what? The malunion. Okay, so this is a case of, yes, absolutely right. Zeel, Ravi, Devashish, all are right. So this is a case of non-union in lateral condyle, but this one we are talking about is supracondylar. Now by these questions, what I'm trying to tell all of you is, once you are doing the TND, I'm presuming these things are clear with you, but I still want to repeat it. Nowadays, don't be just focused upon the fracture. You have to be focused upon what? The clinical presentation of the patient. The clinical presentation of the patient. Okay. So what I'm trying to do now, I'll be putting up a table number 1. We'll make multiple tables for revising all the orthopedic content. Okay. So the table number 1 that I'm making, let's start doing it. The first table that we can make to revise the orthopedic part very, very quickly, table number 1. What I'll do, I'll mark the sites. I'll mark the site and I'll mark the nerve which is most commonly involved in that particular site. Okay, so sites and the nerve involved. And when we go to the further questions, we will note down the clinical tests which are done for them. We will note down what are the special signs to be seen in them, right? All of them. So let's talk about the sites and the nerve involved will make the tabulated part of that. Okay, the tabulated part. So tabulated part, let's start. Number one, I'll start from the hand, upper limb to the like lower limb will go like that in the sequence. Okay, so now you can start making the table. The first site is Guyon's canal. The first site you all know is what? Guyon's canal. Where is Guyon's canal? I hope you all remember the Guyon's canal. The nerve involved in the Guyon's canal is which one? It is the ulnar nerve, isn't it? The Guyon's canal is ulnar nerve. Where is that Guyon's canal? Between the two bones, small bones of the hands, the pisiform and the hamate, under the pisohamate ligament. When the ulnar nerve gets entrapped between the pisohamate ligament, that is Guyon's canal. Number two, you go a little up above towards the forearm, carpal tunnel syndrome. Carpal tunnel syndrome. Carpal tunnel syndrome, which nerve? You all know it is a median nerve, right? We know that it is a median nerve. What are the special tests which are done for median nerve? As I said, we'll make a table again enumerating all the special clinical tests that we can remember at the hand area, at the elbow area, at the shoulder area, at the back spinal area, lower limb. We'll make a different table again. Okay, so carpal tunnel area. Number three, you go a little above. The situation is known as the chiralgia parasitica. So if I say just 6 to 7 centimeter proximal to what? Proximal to radial styloid. Okay, in the forearm area I'm saying 6 to 7 centimeter to the radial styloid. This radial styloid 6 to 7 centimeter above than that is what nerve? It is the superficial branch of the radial nerve. It is the superficial branch of radial nerve, right? And this situation has got a special name. What do you call it? This situation has got a special name. You all know the answer. It is known as what? Chiralgia parasitica. It is known as what? The chiralgia parasitica, right? That would be chiralgia parasitica. Number four, the situation in the forearm, which is known as what? The pronator syndrome, right? In the forearm area, just below the elbow, the proximal forearm area. Okay, proximal forearm, the situation which is known as what? The pronator syndrome. Okay, the pronator syndrome. What nerve is getting compressed? When you talk about this pronator syndrome, it is again the median nerve, right? It is again the median nerve, the pronator syndrome. Okay, pronator teres basically. Number five is our entity called as the cubital tunnel syndrome. The entity known as the cubital tunnel syndrome. What is that cubital tunnel syndrome? What is that cubital tunnel syndrome? Cubital tunnel syndrome is compression of what? The ulnar nerve. Cubital tunnel syndrome is known as what? The ulnar nerve, right? So ulnar nerve at the hand area, ulnar nerve in the elbow area. And if you recall, this year we had a question in the exam. This year we had a question, image-based question in the exam, where they gave you the picture of the lower humerus, okay, and they marked the site medial condyle, right? This mark the site medial condyle, that what is the nerve that is getting compressed under the medial condyle, and that you all know is the ulnar nerve, the medial epicondylar area or the condylar area. It is the ulnar nerve. We go a little bit above. Above than this cubital tunnel area. On the side, you know, the bone is the radial head. Which is the most commonest nerve which is involved around the radial head? You know that it is the PIN, the posterior introitious nerve, which is a branch of which nerve? It is a branch of the radial nerve, right? And this PIN is basically this fracture which is involving the radial head is known as what? The fracture which involves the radial head is known as what? Monteggia. So in your exams, they can very well ask you this question, that a patient after trauma is being evaluated in emergency, and on examination, the patient is having a ability to extend the wrist, but he cannot extend his finger. What is the most likely site of fracture? So site of fracture can be proximal ulna. Can it be? Yes. Why? Because Monteggia is what? Monteggia is fracture of the proximal 1/3 of ulna with dislocation of the proximal radioulnar joint, the radial head, and the radial head will impact the PIN. So never get confused in the exam. Okay, it is the Monteggia fracture which can very well involve the PIN. It happens in the exam. The medial bone getting a fracture, why it can involve PIN? Because of Monteggia. Okay, so don't ever get confused with this. The radial head. Number 7. We go further above, the fracture of the, further on that other side, the fracture of the lateral condyle of humerus. the fracture of lateral condyle of humerus. We know that there is a radial nerve which is there in front of the lateral condyle, and which will actually, do what? It bifurcates here in front of lateral condyle. It bifurcates into two branches, the superficial branch and the posterior interosseous nerve. But the lateral condyle of humerus, as a part of its complication, most commonly involves which nerve? Do you remember that? Most commonly involves what nerve? Lateral condyle of humerus most commonly involves your ulnar nerve. How? It involves it as a late involvement, tardy ulnar nerve palsy. But please remember, tardy ulnar nerve palsy has to be tardy only. That has to be slow or late. And why is this happening? Why is this happening? This is happening when there is a non-union of the lateral condyle of humerus, and this non-union is leading to what kind of issue? This non-union should lead to cubitus valgus. First of all, there has to be a non-union, and that non-union should lead to now involvement of the cubitus valgus. That is a very conceptual thing you have to keep in your mind. Okay, so non-union leading to cubitus valgus deformity causing involvement of the particular nerve. Then number 8 is fracture supracondylar humerus. Then it is a fracture supracondylar humerus. Which nerve? Most commonly involved in the fracture supracondylar humerus is anterior interosseous nerve, which is a branch of which nerve? It is a branch of the this median nerve, right? The AIN is a branch of the median nerve. So please remember, supracondylar fracture, if a patient, they ask you very simply that a patient post-trauma around elbow area is presenting in emergency, okay? There is a patient in your emergency who is coming to you after trauma. After fracture, when he is coming to you, the patient was asked to make a pinch grip between the thumb and the finger like this, but he is unable to do it. Then what is the most common site of fracture? You know what sign is this? You all remember, no? This is a OK sign, right? This is a OK sign, and patient will not be able to do this. That means flexor pollicis longus, and flexor digitorum profundus. These two are not working. If these two are not working, then the patient will not be able to make a what? OK. And the finger and the thumb will be flat like this. Okay. The thumb and the finger will be flat like this. So what is the fracture which most commonly can create this problem? Is supracondylar. So these kind of logics you have to apply while going for the exam, and these kind of clinical scenarios can be very well posted there. Okay. Number 9, the fracture shaft of humerus. The fracture shaft of humerus, it most commonly involves which nerve? Shaft of humerus, it most commonly involves the radial nerve. Okay. Number 10 is the fracture proximal humerus. Injury to the proximal humerus, I must say, it can be dislocation, it can be fractures, like that, anything. So when there is an injury to the proximal humerus, what is the most commonly nerve involved? It is the axillary nerve. Okay, it will be the axillary nerve. And you know that if the axillary is paralyzed, what all kind of problems the patient can have. Okay, we'll make a separate table if a particular muscle is involved, if a particular nerve is involved, what kind of issues one can have. So that movement problem we'll note down later in another table. This is just for sight and the nerve. All right, so that is one. Next we go on to the little bit above area, and that situation is known as what? The thoracic outlet syndrome. That is known as the thoracic outlet syndrome. After proximal humerus, we can talk about the thoracic outlet syndrome. What is that thoracic outlet syndrome? It can be of two types broadly. Thoracic outlet syndrome can be of two types. It can be neurogenic, or it can be vasculogenic. It can be neurogenic or it can be vasculogenic. Okay, what is that neurogenic? You call it neurogenic when it compresses what? Neurogenic is when it compresses the lower trunk of the brachial plexus. When it compresses the lower trunk of brachial plexus. Okay, lower trunk of the brachial plexus. And it is called vasculogenic when it compresses what structure? Subclavian vessels. When it compresses what structure? Subclavian vessels. And if you recall the PYQs, if you remember them, you are aware that the question related to subclavian vessel compression was there in your exam as well. What they asked, this test, remember that? The Roos test, it was there in your exams as well. So subclavian vessel injury can be very well asked in your exams. Okay, that was your vasculogenic. So test, as I said, will make another table, thoracic outlet. Then you have the clavicle injuries, which usually, causes only malunion, doesn't cause any subclavian vessel or the brachial plexus injury. But that is like uncommon kind of thing. We can go to the lower limb. Okay, so in the lower limb, we have the injury site around what? Inguinal ligament. Okay, what is the most commonest nerve that can be involved around the inguinal ligament? If you can recall, around the inguinal ligament, it is the lateral cutaneous nerve of thigh. Suddenly in between of the comment, there is a flag coming. Oh, so you are supporting which team today? Lateral cutaneous nerve of thigh. And this situation is going to be called as what? That's a special name for it. What do you call it? The situation is known as the meralgia peristatica. Remember, the situation is known as the meralgia peristatica. Suddenly the supporter is gone, not a very hard supporter. No, meralgia peristatica. Yeah, so that is lateral cutaneous nerve of thigh. So number 13, after inguinal ligament, we can talk about when there is a trauma related to the posterior dislocation of the hip. After inguinal ligament, when there is an injury around the posterior dislocation of the hip. So what is a nerve? What is a nerve that can be involved at the posterior dislocation of the hip? Any idea? It can involve the thickest nerve of the body. That is sciatic nerve. Okay, that is sciatic nerve. So sciatic nerve, basically, you know, if it is compressed in the hip area after the hip dislocation, or after the surgical, you know, intervention from the posterior side, what that can lead to? That can very simply produce the foot drop. Right, you know, the presentation of the patient will be foot drop. And number 14, we move on to the knee area, the proximal fibula. Proximal fibula. Where in the proximal fibula? You know that it is most commonly the neck of fibula. It is most commonly the neck of fibula. It compresses which nerve? The common peroneal nerve. And again, you know that common peroneal nerve here again can cause what? The foot drop. Now, if I recall again, if I give you a recall again, this was again a question, right? If you remember this NEET exam 2023, how they like tried to trap you there. They gave you the picture like this. If this is, let's suppose, the lower femur, this is the upper tibia, and there was a fibula here. Okay, and they said there are 4 marked sites. Site A is lower femur. Side B is proximal tibia, side C is head of fibula, and side C is the neck of fibula. And how they said? Option A is A, B is, let's say, B, C is D, and D is C. Now they said, what is the most commonest site that involves the PIN? And you know that most commonest site is actually D. And when you go to mark the D, it comes out to be C. Right? And when you mark C, then it has to be ideally D. So that was a kind of trap that was made this time in your exams. So be very, very, because in very, very, you know, special manner, you have to be very vigilant at that time when you are focusing on the question. Okay, so don't get carried away by the like positivity in your mind that okay, it is now proximal fibula, so I'm marking the correct. Be very alert. Okay, this is a kind of trap that they had made this time. So those who might have asked their seniors about this exam, they might be aware of this. No, it was there. So proximal fibula. After that, we go to the ankle area. It is tarsal tunnel area. Okay, it is tarsal tunnel area. In the tarsal tunnel, there is involvement of what nerves? There is involvement of the tibial nerves, right? It is usually the posterior branch of the tibial nerves. It is usually the posterior branch of the tibial nerve that can be involved. And in the foot area, there is an entity called as the Morton's metatarsalgia. There is an entity called as the Morton's metatarsalgia. Okay, Morton's metatarsalgia. What is that entity? Morton's metatarsalgia, it is actually compression of what? It is a compression of digital nerves. It is compression of digital nerves under the metatarsal heads. Okay, I hope all are comfortable with whatever short forms I am writing, MT, metatarsal nerves. No, I think all of being at the post interns and they already have this idea. So do let me know if you find any difficulty anywhere. Calf wasting is also present. Obviously, anything which is like getting, you know, supplied by L4, L5, S1, 2, 3, everything is going to be like showing you the effect, whether it is motor or sensory. Okay, digital nerves under the metatarsal head. So these are the guys, you know, the areas where the particular nerve is involved, where the particular nerve is involved, right? So so I think that is table number 1, and now this table should be able to help you out to, you know, yeah, there you should be able to revise this very, very quickly, that all the nerves, all the areas where they are involved. And as I said earlier, the clinical test, the muscle related issues we will be discussing in another table. I think this is fine. Symptoms of Morton's. Symptoms of Morton is like any other problem. The patient who are diabetic, they have the muscle wasting, and when they keep their foot on the ground, the metatarsal, you know, heads here, they will be putting the effect on the these nerves, as because the muscle wasting is there. So ground and the metatarsal head, and there is a compressed nerve, so that brings a sharp shooting sensation in the foot. Okay, that is a symptom of Morton. All right, so okay, So basically these are, okay, so these are the like different areas. I hope everybody has noted this, and just do let me know, are we like good to go ahead like this only? Would you like to make the tables like that? That is absolutely up to you. Would you like to make the tables like that, or would you like to discuss the question one by one? Whatever you suggest, I can go ahead like that only. Okay, so these are 3 questions, and by this means we have revised the complete area trauma. Yeah, complete trauma with the site where the particular nerve can be involved. Okay, so like this I can try to make multiple tables for you so that we can revise the whole content of orthopedics with the in the form of tables. Okay, so whatever you suggest, I can go ahead like that only. So wherever applicable, we can try to make the table. All right, table form. Yeah, great. Table form. We can go ahead with the table form. Great, great, great. Right. So number 4, sir, can you please explain the last one? Last one means, Chetan, what you're trying to say? You're trying to talk Morton's metatarsalgia. See, Morton's metatarsalgia. Yeah, tables. Got your point, guys. We'll be going with the tables. So basically, okay, so basically, you know, this last one is Morton's metatarsalgia. Morton's is a situation in which is more commonly seen in a diabetic person. You know that in diabetes there is a muscle wasting. So people, when they get up in the morning, when they keep their foot on the ground, these digital nerves, means the nerves which are going to the toes, they will get compressed under the metatarsal heads. And when you put the foot on the ground, they will produce a sharp shooting sensation in the foot area. That is, yeah. Okay. So this is one, Morton's. Let's move on to the question number 4. Let's move on to the question number 4. We have now a 26-year-old volleyball player complaining of severe pain at the lateral aspect of his thumb, which is gradually increasing, all right? It increases on keeping the thumb in the fist and making the wrist deviate ulnarly. Keeping the thumb in the fist and making the wrist deviate ulnarly. X-ray was done and it turned non-significant. All right, then what? So what is the diagnosis? Probably that is a question. So what's the diagnosis? What is most likely diagnosis? What do you suggest, guys? What do you suggest? What are we talking about? D. Okay. So what is the test that we are talking about? What is a clinical test here? Yes, absolutely right. This is decurvane stenosynovitis. So what test are we talking about? Finkelstein. Absolutely correct. And in the decurvanes, what is the most commonest like muscle, or the muscle which tendon is involved? What is the most commonest muscle? What do you recommend? What is the like most commonest muscle involved in this? So what do you say? The muscles which are involved in decurvanes are APL and the extensor pollicis brevis. Are they visible? Are they visible? These two making the boundary of a anatomical snub box: abductor pollicis longus and extensor pollicis brevis. All right. So let's try now. This question is a clinical question which is asking you for the test. Let's see the next question, and then we'll make another table, the clinical test which are done at different locations. Okay, let's see the number 5. Yeah, a 45-year-old football player had a fall on the ground, and X-ray shows he sustained a fracture at the base of his thumb. All right, the surgeon advised for fixation of the injury. Reason told was displacement by muscle. All right, so question number 5 shows you what fracture. First of all, tell me the diagnosis for question number 5. What is the diagnosis for question number 5? What is the diagnosis for question number 5? Okay, so what is the diagnosis, guys? Can you make up the diagnosis? Can you make up the diagnosis? Can you see this fracture over here? Can you see this fracture over here? It is abductor pollicis longus. Diagnosis, nobody is saying. Diagnosis, what is the diagnosis? APL is point taken. APL is a muscle which is attached over here. Absolutely correct. What is the diagnosis? Bennett's. It is Bennett. And why did like the surgeon said that we want to fix it? What is the reason? Can anybody say? Why the surgeon said we want to fix it? Because the muscle is attached over here, and the muscle attached will not allow the fragment to stay in the position. So any muscle, when it is connected to a bone and the bone is getting a fracture, like lateral epicondyle, medial epicondyle, the Bennett, all the time they make it what? The fracture of necessity. It has to be, it is displaced, it has to be fixed. All right, so Bennett. Now you said the muscle involved here is APL. So please remember in the very, very short form, APL, the muscle, APL, abductor pollicis longus, it has got 3 questions for you for your PGME exam, right? It has got 3 questions for you for your PGME exam. The APL, please remember it. 1, the fracture that it displaces is Bennett. Second, the inflammation of APL is known as what? You said decurvane stenosynovitis. Third question, APL. If I may ask you, the APL, what will be the nerve supply of the APL? Can you guys say? Can you guys say the APL? It will be supplied by which nerve? Can you please say? Can you please say what nerve is supplying it? What nerve is supplying it? Can you please say? The APL, that is the third question you have to answer in your exam, and that comes as a muscle of, like, kind of the nerve of exclusion, or you can say the muscle of exclusion in that area. Okay, what is that nerve supplying the APL? So please remember that APL is the nerve supply is, yes, absolutely right, absolutely right. AIN, come on, Ajmal, median, Shanta. I knew this point that majority people are going to answer it as median. Majority people are going to answer it as median, but that is -1. That is -1. You know, it is getting a supply from what? The radial nerve. Why is it getting a supply from the radial nerve? That is a question of exception. See, where is the APL lying? Just have a look. Where is the APL lying? Is it on your flexor compartment? No, it is not in the flexor compartment. Where is it? It is in the first extensor compartment. And you know the first extensor or any extensor, by that means it is supplied by what nerve? By what nerve? It is supplied by radial nerve, or that comes as a question of your exclusion. So please remember, these are 3 questions related to your APL. I hope everybody is clear with this. I hope everybody, yeah. Okay. So basically, I hope everybody is clear. So -1, we have to make it like kind of, okay, kind of +4 we have to make it, no? So this is -1, PIN. So it is by the radial nerve. Yes, agreed. Priyank, you are right. I'm trying to say the nerve which is involved. Okay, so let's try to make for the question number 4 and 5. Okay, for the question number 4 and 5, let's try to recall all the tests that we can at a particular location. Okay, so our table number 2 will be regarding the tables. Our table number 2 will be regarding the test, clinical test, which can be done for a particular like problem. Okay, we'll try to concise, we'll try to make a table number 2. Okay, that will be your table number 2. It is all about the clinical test, for what all clinical test can be done. Please do remind me if I forget some test. Okay, you can also contribute to the list if you wish. Okay, number 1, let's start again from the upper limb. Let's go to the spine, then let's go to the lower limb then. Okay, the first area where we can talk about the test in the hand, basically, I'm not talking about the specific radial, median, ulnar here. That's a separate topic because there are multiple tests there, pointing, index and all. I'll be taking that point away separately, but this one is about the rest of the clinical tests which are done for routine other conditions. Like number 1, we can start again from the carpal tunnel area. Whenever somebody is suffering from carpal tunnel syndrome, okay, carpal tunnel syndrome, you already knew that it is a compression of the median nerve. Now in the carpal tunnel syndrome, what are the clinical tests which can be done? First of all, please mind this point that in the INI exam of 2020, they asked this question that what is the most sensitive test for the carpal tunnel syndrome? The most sensitive test for carpal tunnel syndrome is Durkan's test. Okay, it is Durkan's test. Durkan's is what? Direct compression on the median nerve. That is the most sensitive test. What are the other tests which are related to the carpal tunnel syndrome? What are the other tests which are related to the carpal tunnel syndrome? Number 1 is the Phalen's test. Number 1 is the Phalen's test. Okay, number 1 is Phalen's test. All right, and second, after that Phalen's test, you know about the Tinel sign. You know about the Phalen's test, the Tinel sign. Number 3 is what you call as a tourniquet test. Okay, these are the 3 tests which can be done for the carpal tunnel syndrome. So Durkan will be the most specific one, and other 3s are Phalen's. Phalen's is what? You ask the patient to keep the hand like this. All right, and the patient will be trying to do the test, and there will be a compression on the course of the median nerve. If you get a picture sometime like this, keeping the hand like that, that is not Phalen's, that is a reverse Phalen's. So straight hands, the namaste is reverse Phalen's. When you flex it like this, it is a reverse Phalen's. All right, so this is a compression on the course of the nerve. Then you have the Tinels. Tinels is what? Tapping on the course of nerve. And tourniquet is what? You apply the BP cuff, raise the Mercury column because of the venous engorgement. There is pain in this area. That is tourniquet test. All right, so number 2. What is other test around the hand area? If you can recall something. Number 2 test I can make is what we have just written. It is the Finkelstein test. Okay, it is the Finkelstein's test, the named test. Okay, Finkelstein test. It is done for what condition? We just talked about that. It is the, yeah, reverse namaste and namaste. Chetan is right. Yeah, correct. Reverse namaste and namaste. So please remember, it is not the Siddha namaste. It is the reverse namaste. All right. So de Quervain's tenosynovitis. Okay, it is about the de Quervain's tenosynovitis. All right. So it is about the de Quervain's tenosynovitis. All right. Number 2, Finkelstein test around the hand area. That's how you do it. So you ask the patient to keep the thumb in the fist and go for ulnar deviation. Okay. So if there is an inflammation here, he can't do that. Number 3 test which can be done around the hand area is something known as the Cosen's test. Remember Cosen's test. How to do this Cosen's test? How somebody does the Cosen test? For what condition do we do Cosen test? Diabetic chiropathy in Namaste? No, Nikhil, don't ever get confused with that Namaste sign. That is known as something else. No, that is something different. So in that, Namaste is not possible. The patient keeps the hand like this. Okay, that is a diabetic chiropathy. In Namaste, you have to make a complete hand. In diabetes, the Namaste is not possible. Please remember that. Okay, Cosen test is for what? Cosen test is for what? You ask the patient to flex the elbow and extend, make a fist and extend it for the like use of the extensors. Okay, so Cosen test is for lateral epicondylitis, the tennis elbow. Absolutely right. It is for lateral epicondylitis. That is the tennis elbow. Absolutely correct. Okay, so it is tennis elbow. All right, perfect. Tennis elbow. Okay, in the hand area. Number 4, you talk about the named test around the okay, so we talk about a special sign which is known as in the elbow area, which is known as the Popeye sign. It is not a very like you can say rarely asked kind of question, but Popeye sign. What is that Popeye sign? You ask the patient, you just against the resistance, you ask the patient to flex the elbow. Against the resistance, you ask the patient to flex the elbow. If there is a pop here, right? If there is a muscle popping out here, that is suggestive of what? The Popeye sign. It is suggestive of the injury to the biceps, the long head of biceps. So rupture of the long head of biceps. Okay, rupture of the long head of biceps is seen where? It is seen in the Popeye sign, right? Yeah, you are right. Absolutely, Richa is right. That what is the most commonest muscle involved here? It is extensor carpi radialis brevis. Absolutely correct. All right, the Popeye sign. Number 5. We talk about some important named tests, I'm saying, of the shoulder area. In the shoulder area, if you remember, we talked about a test called as the lift off test, right? The name test as the lift off test. You remember, you ask the patient to keep the hand on the lower back. Okay, you ask the patient to keep the hand on the lower back, and examiner will be keeping his hand on the patient's hand like that, and you ask him to lift it like that. Okay, so lift off test is done for what muscle? It is done for subscapularis. It is done for subscapularis. Okay, then you have a something test here called as the empty Ken test. The empty Ken test. So it is basically, it is done for supraspinatus. You ask the patient to, keep the hand like this and lift it against some resistance. The empty Ken test. Basically, it is done for what muscle? We do this kind of test against some resistance. You ask the patient to basically abduct, elevate the hand, abduction. So it is basically done for the, it is basically done for the supraspinatus muscle. So you can try to test for the tear of the supraspinatus muscle. That is by the empty Ken test. Number 7 is a test that we talked about, this thoracic outlet syndrome. So in the thoracic outlet syndrome, when we are talking about this vasculogenic, okay, thoracic outlet syndrome, when we talked about this thoracic outlet syndrome, we said it is vasculogenic as well as it is neurogenic. So when it is vasculogenic, then we can talk about 3 important tests. There are 3 important tests. Okay, just a minute. Okay, okay, right. So vasculogenic basically has got 3 tests. We can remember by the mnemonic of WAR. WAR. What is that? W stands here for, the W here stands for the right test. WA and R. W is right test. Okay, W is known as right test. Adson is what? This is Adson's test. A is for Adson test. And R is for Ruse. And Ruse is what kind of test? So if you recall, Ruse has been your previous year question of the exam. Okay, so Ruse, Adson and WAR. So WAR is the test basically. So how to do that? The Ruse test is you palpate the you ask the patient to, you keep palpating the vessel. And why are we doing it? Thoracic outlet syndrome, vasculogenic, subclavian vessel. In the last table, we have made it. Okay. So you ask the patient to abduct the shoulder like that and you extend it a little bit. Ask the patient to keep on closing and opening it. And you feel the pulsations here. That's Ruse. Okay. That's Ruse. Adson is what? Adson is you keep on palpating the pulse. Ask the patient to extend the neck and rotate to the side of suspected compression, the pulse again becomes feeble. And right test is what? You just feel the pulse, elevate the hand of the patient like that, and you feel the pulse. That is right test. Okay, so these are the three tests which can be done for the thoracic outlet syndrome. The name test at the upper part of the shoulder area. Okay, and number 8, let's talk about number 8. In the number 8, let's go to the spine then. In the spinal area, the name test, they are kind of important when you talk about certain pathologies. For example, the ankylosing spondylitis. Remember, ankylosing spondylitis. So what were the name tests there? I'll just put the disease as ankylosing spondylitis so that you remember the test for always. In ankylosing spondylitis, you know that there is a fusion of the spine. Remember, there is a fusion of the spine. So what we check? First of all, in ankylosing spondylitis, we check for the sacroiliac joints. Okay, for the sacroiliac joint, what is the name of the test? If you remember, guys, it is known as what we do. It is known as the modified Schauber's test. It is known as the modified Schauber's test. That is sacroiliac joint. And after the sacroiliac joint, then we check for what? Then we check for the restriction. This is my bad, please, my bad here. The sacroiliac joint, this is for not sacroiliac joint, this is for lumbar spine first. I have made a mistake here. I apologize for that. The lumbar spine, it is the modified Schauber's test. And when you talk about the sacroiliac joint, if you wish to check for the inflammation of sacroiliac joint, what are the tests we have for the sacroiliac joint? The test for sacroiliac joint, they are learned as what? The Ganselin's test or the pump handle test. Remember the Ganselin or the pump handle test. So please remember the names, that these are lumbar spine, modified Schauber's test, sacroiliac joint, the Ganselin test or the pump handle test. The name test for the lower back, the spinal area. In the spine only, for the scoliosis, if you recall, we also learned a test called as the Adams test. In our classes, we learned about this Adams test. What was that for? If you remember, the patient of scoliosis, sometimes, you know, they have the, like they are so tall in their stature that on their back you are able to appreciate some sort of scoliosis. Okay, you ask them to bend in front and the scoliosis disappears. That has been all the time because of their long stature, like long stature of the patient. So Adams test, it is done for what? To identify a difference between a pathological versus, I can say, a positional or a postural scoliosis. Postural versus pathological scoliosis. Okay, that is in the spine for the scoliotic curves. That is another named test. Okay, when you talk about now the hip area, let's go to the lower limb. In the cases of congenital dislocation of the hip, you remember, in the cases of congenital dislocation of the hip, we do kind of 3 tests in a child, or you can say 3 kind of movements in the child. What are they known as? Number 1 to be done is known as the Ellis test or the Ganselin's Ellis test or the Galeazzi sign. Ellis test or the Galeazzi sign, right? Ellis test or the Galeazzi sign, that is one. Remember, second test which is done for the patient of CDH, it was, remember, as the most provocative test for CDH. What was the name for that? The Barlow's test, right? This was, if you remember, guys, this was learned as what? The most provocative test for CDH, because it was supposed to dislocate the hip, if you remember that, right? Most provocative test. And in the third test, where you reduce the hip of the patient, is known as what? The Ortoloni test, right? These are the 3 tests you do for the hip joint of the child. When you talk about the hip joint of the adult, if you remember, in the cases of tuberculosis of the hip, when the patient has developed, if there is a patient who has got tuberculosis of the hip, and if the patient has developed what? The fixed flexion deformity. If the patient has developed the fixed flexion deformity, what test do we do? You remember, that was a question that has been asked 3 times in last 5 years. 3 times in last 5 years. What is that? That is known as the Thomas test. Remember, the Thomas test. And last time in the INI exam, it was asked as a sequential arrangement kind of question, if you can recall that, right? Tuberculosis of the hip, that is a Thomas test. All right. Number 12. Let's go down to the knee area. In the knee, we can have the test for 2 different structure. In the knee, we can have the test for the 2 different structure. One is for the cruciates. For the cruciates, for the name test, if you remember, these are learned as the anterior and the posterior drawer test. These are learned as the anterior or the posterior drawer test, or what was the other name? The other name was Lashman. And if you recall, guys, anterior and posterior drawer were done at what kind of flexion of the knee? 90-degree flexion of the knee. Or Lashman test is done at 20 degrees flexion of the knee, right? It is done at 20 degrees flexion of the knee, right? That is number 12. Now, part second of this knee area, it is the meniscus. Part second of this knee area is meniscus. Okay, in the menisci, what are the name tests if you remember? What are the name tests if you remember in menisci? Just a minute, please allow me a minute. I'm missing some links here. Okay, so in the knee we have the second structure called as the menisci. And what are the name tests if you can recall that? The named tests are: 1, the McMurray's test. Remember, patient in supine position, multiple movements done at a time, the McMurray's test. And then we have the second one, which is known as the Epley's grinding test. Okay, which is known as what? The Epley's grinding test. So in the knee, about the cruciate and the menisci. Okay, in the knee area. All right. Number 13. After that, we have the test around the ankle area for integrity of tendo Achilles. When you are checking for the integrity of tendo Achilles, what was the name of the test? Tendo Achilles integrity. The patient lies prone, you flex his knee and you squeeze his calf. What was that test known as? It was known as the Thompson test. It was known as what? The Thompson test. Remember, that was the Thompson's test. Right, so these are the different tests which are usually learned in our orthopedic classes with our part of the routine, details of the lecture. I think I haven't missed out anything. If anyone can point out something special, important which we have missed, I would be happy to incorporate that. Okay, so that is your table number 2. That is all about the clinical test. Okay, so question number 4, 5 covered with the names of the clinical test, the Thompson test and everything else as well. All right, so I think this is fine, everyone. So number 6. Okay, we are going good, I believe. No troubles. If there is any negative point with anyone, please do let me know so that I can improvise right now, because we are in the beginning of the session. Okay, and if anybody is feeling any trouble, because TND fast track is supposed to be like that, we have to revise the content in a very, very short span of time. Okay, so let's see. Can you show the table again? What part, Zeal? What part you want to see? What part you have missed? If you can show Trendelenburg. Oh, very good. Thank you so much. Thank you so much. Yes, Trendelenburg we missed. Okay. Trendelenburg, one of the most important we missed. Very good. Very good. So Trendelenburg you can add on, please. Trendelenburg you can add on, please. Okay. So Trendelenburg, you all know it is done for what? To test for the integrity of abductor mechanism of the hip. Integrity of the abductor mechanism of hip. Okay. So that is your Trendelenburg test. That is your Trendelenburg test. All right, that is again a very, very important test and has been asked like 2 to 3 times in the past few years. Okay, next is a very interesting and important question. A 9-year-old girl, we have a little girl with us who is presenting with gradually increasing pain. Okay, a little girl, 9 years, presenting with gradually increasing pain. So not a trauma question, acute trauma is not there, and there is pain in the this upper part of the aspect of the leg for last 2 months. On palpation, the region seems to be little tender. All right, she was otherwise active, but now for last 2 weeks she is unable to flex the knee without pain. What would be the most likely diagnosis? What do you suggest, guys? What is she suffering from? Not an acute case, not an acute trauma, gradually increasing trauma, localized kind of tenderness. So what are we talking about? Osgood Schletter. So what do you see in the X-ray of the Osgood Schletter? You all can see the fragmentations here. You all can see the fragmentation here. Okay, so yeah, valgus stress or varus stress, they don't have any specific name. No, valgus stress or varus stress can be done for any collateral. Elbow also valgus stress, varus stress. Okay, so I haven't kept that. That's not an important name test. So okay, so it is about what do you understand by Osgood Schletter? If everybody recalls that, what do you understand by Osgood Schletter? What kind of trouble is that? Osgood Schletter. We know that it is what? Osteochondritis, right? It is what disorder? It is osteochondritis. So what are the different disorders? You know, yes, absolutely right, everyone. Anjali, Ravi, Buddy, Lakhan, everybody is right. That it is osteochondritis. Okay, so let's make a table here. What is the next question? That is different. So for question number 6, we can make our table number 3. The different osteochondritis at different locations. Okay, so X-ray would be, please remember, the X-ray would be same. The table number 3 is about different osteochondritis. What all bones? What is the meaning of this word osteochondritis? I'll just take a quick recap of this. Osteo, the bone, chondro, the cartilage, inflammation. And who has got like more of the cartilage, a child or an adult? Obviously the children's, and that is why they are more prone to develop most of the osteochondritis, okay, majority of the time. So osteochondritis, you know, what are the different sites and what are the different locations for different osteochondritis? Let's make a table of that. The table number 3. Okay, yeah, tractional is one. Okay, so I'll make the site, name the site, and I'll say the names. What are the names given to these osteochondritis? Okay, we'll make a table of that. So what are the sites? Let's start again from the upper limb, then spine, then lower limb, same sequence. Okay, site number 1 is scaphoid. Site number 1 is scaphoid. Okay, scaphoid is preserves. Scaphoid is preserves. All right. Second one is lunate. Second one is lunate. Lunate is what? Cayenne box. Lunate is what? Cayenne box. Number 3, capitulum, elbow. Capitulum, elbow. It is Panners. It is Panners. Number 4 is at vertebra. In the vertebra, we can have two kind of osteochondritis. Okay, two kind of osteochondritis. One is what you call Scheuermann's. One is what you call Scheuermann's, and one is what you call Cave's. So remember, C, Cave's is osteochondritis in the central area. Scheuermann is the outermost, this ring area. So Scheuermann here and Cave's in the central area. Okay. Number 5 is the head of femur. It is the head of femur. What do we call this? This is known as Perthes, another very, very important topic. And when we will talk about the attitudes of the hip, we'll make a table where all the attitudes have to be combined. Like Perthes is a very, very important situation in a child. Okay. So here Perthes is not asked as like typically osteochondritis. It is asked as the attitude. How the patient comes to you, abduction, adduction, internal rotation, external rotation. So that will make head of femur. Then we talk about the lower femur. You remember what is the most commonest site of osteochondritis in the lower femur? The condylar area. It is a lateral aspect of what condyle? It is lateral aspect of what? Lateral aspect of what condyle? Lateral aspect of medial femoral condyle. Lateral aspect of the medial femoral condyle. Pani. Lateral aspect of medial femoral condyle. Okay. Pani, please. Lower femur. So in the lower femur, it is a lateral aspect of medial femoral condyle. Next one, number 7 point, is when you're talking about the osteochondritis in the front of tibial tuberosity. This is the one that we are talking about in the question. You answered it very, very correctly, that she is suffering from Osgood-Schlatter disease. So please remember, around the knee, we have got 3 kinds of osteochondritis. One is lower femur, the tibial tuberosity. Lower femur, the tibial tuberosity, and the lower pole of patella. Lower pole of patella. In the lower pole of patella, what do you call it? It is named after 3 friends, 3 people, right? What is that known as? The SLJ syndrome. Remember, Sinding, Larson, Johnson syndrome, SLJ syndrome. The 9 one is around the calcaneum bone, where you can see the fragmentations around usually the posterior aspect of the calcaneum, where there is an attachment of this tendo Achilles. It is known as what? It is known as the Sever's disease. Then we have the osteochondritis of the navicular. Okay, about the Trendelenburg ABC, it will come as a question. I think there is a question in the exam about in this paper about the Trendelenburg. So we'll discuss it there. Not to worry. Okay, not to worry. So navicular is osteochondritis of navicular is known as the Kohler's disease. Okay, number 11 is around the metatarsals. When it occurs around the second metatarsal, it is at the head of the second metatarsal. It is known as the Freiberg disease. Okay, it is known as the Freiberg disease. And when it occurs at the base of fifth metatarsal, base, it is known as the island disease. It is known as the island disease. Okay. Now somebody said that there are tractional osteochondritis as well. What is the meaning of tractional osteochondritis? What is the meaning of tractional osteochondritis? Tractional means where there is a constant pull of some muscle of that some tendon. What are those ones? You see the fifth base here, It is connected to what? It is connected to peroneus brevis, no? It will have the tractional one, severs, tendo-Achilles, tibial tuberosity, and the lower pole patella. These are all what kind of osteochondritis we have? These are all known as the tractional osteochondritis. Okay, these are all known as what? Tractional osteochondritis, where there is a constant pull of some muscle or some tendon. Okay, these are all the tractional osteochondritis. I hope this is fine with everyone. This is known as the tractional osteochondritis. Okay, so tractional osteochondritis simply means that there is a constant pull of this muscle. Yeah. All right. Okay. So this is your table number 3, I believe. Yeah, table number 3 for osteochondritis. All osteochondritis had where there is a constant pull. Yeah, constant pull means the muscle is trying, the tendon is trying to pull. No, lateral epicondyle is having attachment of extensor tendons, flexors here, tendo-Achilles calcaneum. So obviously they are trying to pull the bone, or there is a constant, attachment there. The pressure effects that is creating this tractional pull, and that is creating the osteochondritis because of repetitive stress or frictions. Okay, so this is your table number 3 for osteochondritis, the topic number 6. Then we have the question number 7. Question number 7, 32-year-old hockey player started having gradually increasing pain over his lower back, now started having radicular pain as well. X-ray was non-significant in the AP views and the lateral view, and X-ray oblique view was ordered and shown here. Which of the following is the most likely diagnosis? What do you suggest? What do you suggest? What you are able to see? What view is being shown here in the X-ray? If you can just observe this view, what view they are trying to show? It is oblique view. It is the oblique view. Yes, absolutely. And oblique view, what you are able to see? If there is a normal oblique view, what do you see? You see a normal Scotty dog appearance. Remember, normal Scotty dog appearance. And in Scotty dog appearance, each part of the dog is getting formed by some part of the vertebra. For example, if you observe this eye of the dog here, this eye of the dog is made by what? It is made by the pedicle, correct? The eye of the dog is made by the pedicle. This upper one, the upper ear, basically here you see this one, the upper ear is made by what? This ear is made by the superior articular facet, the superior facet. Okay, if you observe the front paw of the dog here, it is made by what? It is made by the inferior facet. And this neck area, which is kind of broken here, and the neck which is kind of broken here, it is made by what? It is made by pars interarticularis. It is made by what? The pars interarticularis. Okay, it is made by what? Pars interarticularis. So what condition are we talking about? Yes, spondylolysis. Absolutely right. Okay, I do believe everybody knows the difference in these 4 terminologies. Spondylolisthesis. Listhesis is what? Slip. Listhesis is slip. Losis is what? Degenerative changes like osteophytes, like the decrease in space, like the deformations. Spondylitis is an inflammatory change. For example, what? Ankylosing spondylitis. So inflammatory change. Okay. Now for this listhesis, if somebody asks you, what is the best view for listhesis? What do you recommend? What is the best view for listhesis? The best view for listhesis is what? Best view is always a lateral view. And if you recall, when there is a significant, slip, when there is a significant slip in the AP view, what are you able to see? In the AP view, what are you able to see? Do you remember this slip, complete slip of the L5 over S1? What that shows you? It shows you what sign? Inverted Napoleon hat sign. It shows you what? Inverted Napoleon hat sign. Remember the inverted Napoleon hat sign? Absolutely correct. So whenever they say Scotty dog appearance, so appearance, remember, is always normal. Appearance is normal. If they use the word instead of appearance, if they say Scotty dog sign, then sign has to be a pathology. Okay, sign has to be a pathology. So Scotty dog appearance or the Scotty dog sign. Okay, this is about this particular question, the oblique view. Yeah. And I do believe that you all know, if for some reason, if you wish to fix the spine, if you fix the vertebra, what is the screw that you use? Remember, if I want to operate on the spine, then what screw has to be used? That has to pass through the eye of the dog. What is that screw? Everybody knows that. What kind of surgical fixation we call it? What kind of surgical fixation do we call it, guys? So it is basically your pedicle screw. Everybody remember? Yeah. So that is what you call the pedicle screws to fix the spine. All right, that is a pedicle screw fixation. Yes, absolutely correct. Okay, so I think now we can, it's almost 1 hour of the session that we have done. So what we will do is, now the open YouTube live session will be closed and we will be making a different link for you, and in a while, I'm here only. In a while, the link will be given to you, a new link will be provided, and we will continue from the question number 8. So that's not a big break, that's just a change of the link. All right, so we'll be starting and making many more tables like that only to revise the complete orthopedics. So stay tuned, I'm just coming back with a new link.